And we're live.
All right, everybody, welcome. So we're here. We're back up in Newark for the first time in several months. Today is match day, so we did great. We got 7 people in the match from all over the country, so we did outstanding. So now we are officially the largest fellowship in the world, and come check us out on the website, www.emsfellowship.com. Or follow us on Twitter, or follow us on Instagram, or follow us on Facebook. I've been getting lots of emails from people lately. I know there's like 7,000 to 10,000 of you out there. So like I got an email from Indiana that the guys all watch us. A shout out, and I think we're scheduling a date where I'm coming to Indiana to give everybody a lecture there. We have added our some new stuff this week or in the last month. We're adding our Nitronox field unit to our physician vehicles. We added, we have the transesophageal echo, so we're about to send that in for a case report, first pre-hospital transesophageal echo in the world, and we are doing it right here in New Jersey at the EMS Fellowship. So we're going to catch up on stuff. Please ask us questions as we go along, and it's great to be back up in North Jersey for the first time in a long time. So here we go. Let's just start with interesting cases. Who has interesting cases?
Yeah, I mean, I have one. So I had a patient who, elderly, 80s-ish, came in complaining of tooth pain was her like major complaint. She says, I'm pretty much healthy. She said, I have something wrong with my heart. I don't know what it is. I take an aspirin every day. And that's all she knew. No surgeries. She's overall well appearing. And her vitals are pretty stable. Actually, I was surprised for somebody who had like a heart history. She was, I would say, on the like hypotensive side, like 100 systolic, but normal heart rate, normal rhythm, and physical exam-wise, I really didn't appreciate much there. And when I started asking her about the history, she said, well, I was feeling fine. I did fine all day. And then all of a sudden my tooth started hurting, like my whole mouth started to hurt. And I said, so now, not one side versus the other. And she said, no. And I said, okay, so what happened that made you come to the emergency department? She said, well, my mouth was hurting, and then my neck started hurting, and then my chest started hurting, and now my back hurts, and I can't get it to stop hurting. And I was like, that's really weird, right? Like, it was almost like I was reading like a board's like prompt, because I was like, oh man, I wonder if this is a dissection, and right. But when I got the EKG,
when nothing makes sense, think vascular.
Right, exactly. I'm like, what's the one big red tube in the body that connects the teeth, like the head and the neck and the torso? And I was like, that's, maybe she's dissecting. Her EKG was very interesting. It was, it looked like Wellens. And she had these weird T waves like on all the precordial leads, and I was like, man, do I call this because of the way the EKG looks? Maybe she's having an atypical presentation of just an MI. So I called cardiology.
Maybe she's dissecting through her coronary.
Right, and so and I called cardiology, and they had like 20 minutes earlier been in house putting a stent in somebody who had like a straightforward anterior MI. And I described the EKG to him over the phone because it wasn't working for me to send it to him for some reason. And he disagreed. He said, no, this doesn't sound like a dissection at all. Her vital signs are not consistent with a dissection. The EKG sounds like it's a proximal occlusion. I would medically manage her and put her in the ICU. So he said he would start heparin and put her in the ICU. And I said that made me uncomfortable because there was just something about her that made me feel weird. And so I ended up, he said I wouldn't scan her because that's what I was asking. I was asking for like some support, like, do you think I should scan her? And he said, no, I should just put her in the ICU on heparin. And I was like, no, I'm going to scan her. So I scanned her, and she had a huge dissection from all the way up like to the carotids all the way down to like just above the renals. And it was like the entire anterior wall of the heart was dissecting.
Long-standing hypertension, diabetes?
Yeah, no diabetes actually.
Long-standing hypertension.
I think so, but she wasn't taking anything.
Guessing.
Yeah, she wasn't taking anything for the hypertension, at least currently. And her blood pressure never spiked. There was actually a point when she dropped for like 20 minutes, and I was like, oh no, like, I hope that this doesn't go the opposite direction. As she was in the department further and further, she was like, I feel very hot, I'm sweating, and she's like, I'm having trouble breathing. And that was her biggest complaint, became dyspnea. And it took so long to get ground transport like going that, because we were at a place where we didn't have vascular available, that we were like, well, we're going to fly her. It's just taking too long, let's fly. And then we got the helicopter on board, and then they canceled because of weather. And so she ended up going by ground anyways, but apparently made it to the receiving hospital and made it out of surgery. So I don't know.
Because in the old days, it wasn't that long ago. I mean, you have to have a proximal dissection to go to the OR with cardiothoracic. If it was distal to the left subclavian takeoff, right?
Right.
And you just you get nothing done, right?
It's
You
a
get
type B, right?
admitted,
Yeah.
right? You get admitted by vascular, and there's no treatment, right?
Right.
That's standard medicine for a million years. And then one day, not that long ago, somebody from vascular said maybe we can stent the lead point of where the dissection is, even if you dissect all the way down to big B.
Mhm.
So people started to stent stent in the aorta where the dissection starts from, even if it's a type B, right? So, but the standard of care is to do nothing and just put them in the
Right.
ICU like on esmolol drip or something else, and just keep their blood pressure low. The only thing in 2018, I keep somebody's blood pressure really, really low for on purpose in general, or at least something I drop them from a high number to a low number really, really fast. Nothing else do I do that for.
Right.
So that's interesting. So
I wish I brought her EKG, because I kept a copy of it because it was so textbook. I was like, man, if I didn't know anything about this patient and you handed me this EKG, I would say this is Wellens 100%.
right, or it's a classic someone with chest pain with a stroke or something like
Right.
two systems think vascular.
Yeah,
right?
yeah. So it was cool. It was an interesting. It was one of those things where I'm like, man, board's questions really are real. Like,
I hope you called the cardiologist back.
oh, I did.
And let them know what
Absolutely,
happened.
100%. I was like, hey, just so you know, I'm sending that patient to this other hospital because she's got a giant dissection.
Nice.
So yeah, and I'm glad I did not give heparin.
I was on the phone not that long ago with this guy named Al Sacchetti, who's a well-known ER doc, and so we brought somebody to his hospital, and it was somebody who was having like stroke-like symptoms with chest pain, and they was having a little bit of this, a little bit of that. So I called him and I said, "Al, I'm just wondering, we brought you this case. I took the consult call. What do you think?" He goes, "Mark," he goes, "I don't know what the heck is wrong with this lady. I sent her right to CAT scan unless she's having a dissection." And a few minutes later, he calls back and goes, "She's having a dissection." Right? I'm like, right, nothing made sense. And he
Right.
put her in the scanner, and she's having a dissection.
Yeah, that's pretty cool.
So, and then, so we don't really carry esmolol pre-hospitally, so you just like low pressure, I guess, metoprolol.
Yeah,
It's what to start with. I guess you can give labetalol, oral labetalol, but typically a straightforward beta blocker
Yeah,
is pretty good.
yeah.
And
I had them bring up esmolol and have it there if she ever got hypertensive, but she maintained her pressure almost the entire time except for that 20-minute period where she became hypotensive and I
right,
got a little nervous.
right,
But she did good.
yeah. All right. Anything else? So this is why we don't routinely just give, if we're suspecting dissections, why we don't give like aspirin and stuff to
Right.
everybody. Although the studies which have looked at people on aspirin getting dissections, they did okay. Right?
Yeah.
Right. It's if you make the mistake and you give it, it's not that big a deal. And what do we do for people who are dissecting their carotids? We actually heparinize
Yeah,
them,
that's true.
right? So it's not the worst thing in the world, but it's certainly it's why we don't give aspirin to like stroke patients, because we worry about them
Right.
bleeding bleeds or hemorrhagic conversion, right?
Right.
Or at least before we get to CAT scan, I should say. Any other interesting cases this week?
I have one. It was a very interesting case. It came to the hospital via paramedics for unconscious, unresponsive. When we finally got to her, she was having kind of a 80-year-old female, worsening dementia. She was having a right-sided gaze, and then this clonic movement on the right side, but just the right side. The left side wasn't really moving. So without any other information, what are you guys thinking right off the bat?
Yes.
It was a seizure, is it a stroke?
Right.
And so she wasn't moving one side of the body.
It was moving, but not the same.
What's that called when you can't move one side of the body after a seizure?
Todd's process.
Todd's paralysis. How long does Todd's paralysis last for? What's the longest Todd's paralysis lasts for? I remember some very old. It's always interesting to ask very old doctors things, right? So one guy who's an old neurologist said to me, "How long did it last for?" And I guessed. What do you guys think? How long before Todd's paralysis is and Todd's paralysis not going away?
Like 2 or 3 hours is what I guess.
So he goes, the answer is 6 days. And I
What?
said,
What?
And I said, why 6 days? And he goes, because I'm a very old neurologist, and I've seen people have hemiplegic after a seizure, after 6 days get totally resolved. So
Wow.
since that's the longest I've seen, that's what I tell
The
you.
end of one.
Right. 6 days. But I guess the point here is you can get prolonged hemiplegia or some neurologic finding after a seizure, which can take a longer time to go away than just a couple of hours and then still be okay. I guess that's his point. All right, keep going, sorry.
Yeah, so at that point, I gave 2 of Ativan and sent her to the scanner as a code stroke or code fast or code back call, whatever your people use. And the CT head was negative, and the tonic clotting movement was still there, so I gave 4 of Ativan. And then when I reassessed, the whole time oxygenation was fine, so I wasn't going to kind of go down the route that I needed to paralyze her and take her airway. But it was in the back of my head the entire time.
So this is a great question now. So seizures, benzo's not working. What's the differential? So seizures, benzo's not working. What's the differential?
So we just took boards, so
So you guys know everything.
isoniazid toxicity.
So INH, so something on TB,
It's
class.
sodium,
What else?
like hyponatremia,
Right, so sodium,
hypoglycemia.
right, hypoglycemia, sure. There's hypoglycemic hemiplegia, right, which is a
Right.
rare phenomenon that can happen. What else?
I was-
Lidocaine
I was gonna
toxicity,
say some of the
lindane can do it.
Even maybe like serotonin syndrome or something
and
where you have
These are anticholinergics, all the anticholinergics. What else?
Can TCA, something like TCA. I mean,
TCAs, of course.
sure.
What else? Are we forgetting anything? We said all the anticholinergics. We said all the drug-induced seizures. Oh, certainly cocaine, some pathomedics.
Oh, sure.
Right, cocaine-induced seizures. What else? Besides all the usual stuff of pathology, tumors, all that stuff. All right. Okay.
So after the 4 of Ativan, the tonic clotting movement was still there, but it was more of a tremor than a tonic clotting movement. So I wanted to give phosphine. I couldn't find it in the order sets, so I gave Keppra, about 20 per kg, and it went away.
Right, so Keppras are new Dilantin. You have to check
Yeah.
levels, right?
So
Is there any reason you shouldn't give Keppra to everybody?
no?
Actually, there's one reason. So I worked with a neurologist.
Renal insufficiency?
No, it's actually not. It's really not. It's a mood disorder. So anyone in underlying mood disorders, it can precipitate suicidal thoughts and increase mood-like symptoms.
Hmm.
A couple neurologists have told me that. So that's it.
Isn't a lot of patients?
Probably not. I don't know how often it occurs, to be honest with you, but I've been told by neurologists that it's not the ideal anticonvulsant for those mood disorder patients. But
Really? That's such a great safety profile.
it is, exactly. So it's like a
Have you guys started the average adult Keppra?
load them with a gram, maybe
And then discharge them on,
500 BID.
BID.
as a neurologist, just say you should never give anything less than 1,000 BID to the average adult unless they're renal insufficient, because that's not what the package insert says, even though it's a lot of people get 500 BID. So it's interesting, I guess. But the good news is we don't have to check levels.
Yeah.
Okay.
So with this case, I shotgun labs, and they came back. But by the time the CT was done and everything, I talked to neurology. Of significance was the sugar was 1,360.
That's pretty
Yeah.
significant.
So,
Sodium was 147, not really impressive. GAP was
I would expect the sodium to be much lower,
right.
right? I would expect the
13,
sodium to be much lower because that patient's going to eventually be hypernatremic when you
Exactly.
correct the sodium,
Yeah.
right? It's a whole other it's a whole other discussion. What's a sodium correction?
0.6.
I mean, everybody will give you like a different number, right? And the literature is not very evidence based.
So you did mention hyperglycemia as a cause earlier.
Yeah, that makes sense. What was the serum osmoles?
I didn't get that far.
Probably
I need to go back and look it up. But at that point, I just called ICU.
So the patient was in hyperosmolar stage.
But I was able to talk to the family more, and what they told me was the patient was actually awake, alert, fine in the morning, and then fell, and then this occurred. So that kind of goes against the hyperosmol. That's what
I'm gonna give it insulin bolus, right? Something
I
silly.
know.
I never understood this. So when I was younger, I always got taught that in adults you give an insulin bolus for DKA and in children you don't. And that never made any sense to me, right? Something magical happens when you turn 21 that you don't get insulin bolus.
Right.
And then this has been now studied in adults and children, and you don't need insulin bolus on anybody, right?
Right.
There's no, it's all just kind of made up. You can just put somebody on insulin drips. You don't need to bolus anybody. It doesn't help you get out of a decay any faster. All right, so that's a pretty high blood sugar. I'm not sure highest blood sugar you've ever seen. Well, it's
1560.
1560. That's pretty respectable. That's a high number.
Yeah,
How'd they do?
not very well. It was
The
a first time presentation too.
really.
Yep.
Wow. Yeah. I mean, how many days were they sick at home before they present?
It was like the flu-like
Must take a long
symptoms,
time.
vomiting, diarrhea for like 3 days or 4 days, very behind.
60. That might be my highest. Yeah. Anybody else seen higher than that? All right. Anything else with that case?
No.
So I don't know what I would have done. I mean, I just had, more benzos, and if benzos don't work, then ketamine.
Yeah.
Right.
Well, that was my next step. Would have been to go to ketamine and possibly intubate.
I just got called. This was last week. It was a 3-year-old. They were speaking to somebody else. They called. They had a kid with hydrocephalus who was in status epi, so seizing for 20 minutes straight. They were in an area of New Jersey that was not near any pediatric hospital whatsoever. So they were they were either going to a local community hospital or they had another hour drive or 45 minutes. So they were kind of stuck, and they got orders for, they couldn't get an IV in, they didn't put an IO in yet, so they got orders for Ativan sub-Q. Not a good choice, right? We don't like Ativan sub-Q. But they got orders for this, so I basically, and they gave it twice. And so I said, let's give, the kid had known seizure disorder, but was seizing nonstop for 15 minutes. So I said, let's just try and give some intranasal Versed, and try and get an IO in, because now the kid is in status, and if you can't get an IV. It's very small for their state of age. And so and then what did I say? I said, if the benzos don't work, let's switch to ketamine, right? And, but I got a call back that the Versed and intranasal were fine. So we're giving ketamine for refractory seizures, right? There's literature both in adult and pediatrics for refractory seizures. Give ketamine. What else? Are you giving ketamine for refractory seizures?
I haven't.
So we don't see probably in the ER that much kids in status, because usually it's going to resolve before they get
Usually,
there.
if they're still in status, we just go ahead and put them on a Versed drip.
Right, so we don't. Given like an anti-epileptic, we don't have pre-hospital, right? So
Right.
we don't have anything pre-hospital. So it's either benzos or then ketamine, and then benzo drip. We tend to not drip too much pre-hospital. We tend to like bolus just to kind of stop it.
Right.
Plus, it's certainly dangerous for us to have somebody in stats at the pre-hospital and like flailing on the stretcher and moving in the house, and then we can't load them to bring them to the hospital.
Right.
So it's easy. Anything else?
What dosing is it for? I've never heard of ketamine for refractory.
Yeah, so there's
disease.
about 10 papers on it. There was another peds ER in our state who never heard of it, so I sent them all 10 papers on it. And so how do you dose it? Anybody?
I was going to ask you that for the seizures. I'm not sure. Is
Yeah.
it just the dissociative dose?
Yeah, but I'm actually giving a dissociative, not subdissociative. I'm giving a bigger dose because that's what I did in the study.
Yeah.
I mean, the subdissociative would just work for pain. So I'm
Right.
just starting out for a one, right? And but only for refractory.
Yeah.
I mean, this was a person who actually had 3 benzo doses, and the kid was still seizing.
Sure.
And then I had to call this community hospital and explain to the doctor where you're getting a 3-year-old, like it was 3-month-old or a 3-year-old, but to a community hospital, it's the same thing. Who is in status, and why we can't bring the patient anywhere else because we're stopped. It was a CHOP kit, so they just had to take the kid there and then fly them to CHOP, which was fine. But driving a CHOP would have been like an hour by the ground, and that would be too much for somebody still seizing. Okay, anything else? No.
I have a quick question, but I'm just wondering, at what point are you deciding that you're going to intubate these patients in status? Like, if their seizures are controlled on the Versed drip, but they're still oxygenating fine and they appear to be ventilating fine, do you just put them on capnography and monitor them that way, or are you intubating every single patient that you're starting on a drip?
No, I'm actually intubating very few people, but listen, depends upon your hospital's resources.
Right.
You know, some of these are subclinical, right? And you have to get continuous EEG to figure out to start with.
Right.
But, you know, generally our big problem is if the seizures not stopping despite everything, which usually isn't the case. It's pretty rare that you have somebody in status that you can't help whatsoever with everything you have to offer. And eventually, I mean, between Keppra, between Dilantin, between Phenobarb, between Depacon, usually you can stop them and putting them in a benzo drip at the same time and giving benzo bolus. So it's pretty rare. But if their acidosis continues to get worse and worse and worse despite every treatment, then I'm intubating them. And that's my breaking point. Worsening acidosis despite all the meds. But I think about it, I remember having a few of these cases over the years, but just not that many. And this was before like Keppra, this was before Depacon, this was before. This is when we only had like Valium, and nothing.
And you're
nothing
just
was working.
you're just hyperventilating them to.
Yeah, I'm trying to help blow off the
portion.
acidosis that's happening because they're in status.
Yeah.
But again, I think a pretty uncommon scenario. And now, now there's these papers about ketamine, and ketamine drips for status being really good. I just had somebody in adult ICU here who was in status for like a couple of days and nothing was working. And they finally, one of the ICU residents, read something about ketamine, put the person on ketamine, and the seizures stopped.
Got it.
Right. So, in fact, I would say that's a pretty radical statement. In the next 10 years, ketamine will be our first choice for seizures because ketamine works by multiple mechanisms to stop a seizure, whereas benzo just stops it by one.
Right.
Right. So I think ketamine will be our first choice in the next several years because benzos are so titratable. Will it affect your stroke volume? We know from what's the book? A famous drug book, not Robertson Hedges, but it's a famous drug book, and we know that benzos diminish your stroke volume by about 15%, 1.5 on average in all comers. If you're a little old lady who's dehydrated, 15% means a lot to you. The average euvolemic patient or a child, 50% means nothing to you, so you don't drop your blood pressure. But a little old lady who's volume depleted, I would worry about a benzo, but not much else, right? So, and then you never know what's going to happen until you get the first dose of benzo, right? It's sort of like a joke how the dose is 0.1 per kilo. How many times can we give dosage by per kilo? It's actually, that's the dose, and then we need no more.
Right.
Benzos have a huge range, and you never know what's going to happen until you get the first dose. Right. That's why starting out low and going high, is fine.
Last status I had was actually a hypocalcemic patient, and I ended up using ketamine. Because in his case, whenever he broke his seizure, his post-ICMO state was extremely agitated, and he was very big. And I was at a community hospital with nurses who were overtasked, and so the patient kept trying to climb up in the stretcher, and his family were there, and they're like, he keeps trying to hurt himself. Like the seizures would subside and go back and forth. So I gave him ketamine, and it did calm him down a lot, and he stopped seizing, but I also used it as an induction agent because at that point we decided to sedate him, and I ended up using ketamine drip for his post-sedation after his tube, and he was great. I didn't even have to add on the benzo drip I wanted to before I sent him up to the ICU. Right. So it worked very well for me.
Is there anything ketamine doesn't fix? Like ketamine and kale.
You say kale?
Ketamine and kale. They can just put the two together. It would cure everything. All right, so that's good. Anything else with seizures? I guess that's it. So the sodium and calcium, and you shouldn't correct the sodium too fast, right? So so if somebody's seizing or altered anyway, and they're hypernatremic, then we give hypertonic saline. How much do you give?
I do 5 mLs per kg until they stop. But that's repeats.
Yeah, 5's a healthy number, right?
Yeah, we do 5.
5's a healthy number. Usually I tell most people 2 mLs per K, but 5's pretty high.
Maybe
I was going to say 2.
They say 3 to 5 mLs per kg, but we usually just go with the 5.
So and what's the risk for doing making sure them go back too high too quickly?
Cerebral condylosis.
Right, that's been renamed, right? So it's not really cerebral. So it's called cerebral myelinolysis because it just doesn't affect the pons; it affects the whole brain, right? So they've reclassified it, and those initial studies where people got that, who were those patients? They were all pregnant women, right? Mm-hmm. So it's much more common to happen. They were pregnant women and children, so it's much more common to happen in pregnant women and children than it is for the average adult. But if you think about it, how many interns prep sodium too quickly, and most people do absolutely fine,
Right.
except in certain populations they can get sicker.
Yeah.
All right. Any other? So we get to the articles. What's the first article?
What order they're on? Website.
I think Dan is
Yeah.
the first one.
Yeah, I think this is the initial evaluation of the efficacy and safety of in-hospital expendable hemostatic mini sponge use.
Oh yeah. So let's stop. So somebody out there in the world wanted us to introduce ourselves. I guess we'll do it since we're in Newark. So Navin, you want to go first?
Should I move?
Yeah,
my
turn the camera on yourself so they can see the man behind the camera.
Alright. So I don't even see the camera right now. 1 second.
There's a
So-
lot, okay.
Hi, I'm Navin. I'm one of the associate program directors here. EMS and disaster boarded, EM boarded. That's it.
All right, it's good.
Hi, I'm Jocelyn Joseph. I'm one of the EMS fellows this year. Loving it. Here in New Jersey.
Oh, yeah.
I'll see you on the road.
Yeah. I'm Janae Holbein. I'm also one of the fellows this year. Also enjoying myself very much.
I'm Tina DeBari. I'm third year PEDS EM fellow, doing my EMS rotation. I've had a good experience so far.
Hi, I'm Dan Goltz. I'm finishing up my EM residency at Coney Island, starting as one of the incoming fellows in January.
Yeah.
All right. And then Jamie.
I'm Joe Bosco Bella, one of the first year EM residents.
And Mark Merlin, the program director.
I'd be very impressed if they didn't know who you were by now. They
Yeah.
clearly weren't
Who
listening.
wanted us to do that?
I don't remember.
Anyway.
Hi, Dad.
All right, there's no
Yeah,
problem.
my grandmother.
He didn't know. They didn't know who anyone was. You know.
I
So.
see. Are they physicians? Are they doctors?
No,
But they
no, my
watched
dad's a
anyway.
pharmacist.
Yes.
Yes.
Oh, all right.
Because
all
they
right.
support their children.
Right, of course.
My 83-year-old grandmother watches us too.
Yes.
So hi, Nana.
Okay, first article.
Okay, so basically what this article was looking at was the XStat device, which is the sterile, non-absorbable, radio-opaque compressed sponges. It was looking at the, especially used for like these junctional bleeds. So I guess the evidence is really good for tourniquets for like extremity trauma. But this is one of the new up and coming things for junctional bleeding, especially in the groin and the neck, perineum, axilla, those kind of places. So it was looking at, well, I guess it's Kenji Inaba, who's pretty well known in the trauma literature. LA County, they looked at over a year's worth of trauma and pulled about 10 patients out, which kind of were ideal candidates for this. So it started out kind of with a case study about a 20-year-old female that had multiple GSWs, including one significant one to the right groin that was bleeding. The patient was hypotensive, tachycardic, not really amenable to a tourniquet, but they tried pressure. So they used this XStat device. The patient still got a laparotomy, 5 units of PRBCs, and ended up finding that they had a complete transection of the profunda femoris artery. So it was also kind of looking at all the so it highlighted these 10 patients. They said 8 of them were identifiable arterial injuries, and 9 out of 10 of these patients, the first deployment stopped the bleeding. They also said half of these were junctional bleeding. I'm not sure if that meant half the 10 or half the 8 with the arterial injuries, but so most of these actually stopped after 1 deployment. They looked at the dwell times, how long the device stayed in before definitive treatment. They looked at complications, deaths, embolic events, and all that. It looked like 2 of the cases had retained sponges after definitive treatment and had to, which were identified after the initial X-ray after treatment. There were no deaths, no embolic events. And then one of the complications they had also was this: one patient had muscle necrosis, developed rhabdo, and got AKI. They said that the device had stayed in for about 40 hours. So,
Sorry.
so they were mentioning that for the manufacturer, it's safe to leave in for about 4 hours, which a lot of these exceeded the 4 by a long time. They said the median was about 15 hours, but ranged anywhere from the 1 to 40 hours. Yeah, so I mean, it looks like, it's a small study, like 10 patients, but it looks like it's definitely something that can be used in the future. I was looking at some of the alternatives. I guess right now the biggest thing we use are like Foley's. If you have the junctional blades that you can't control, so you basically just put the Foley in and expand the balloon to try and tamp out the bleeding. But they were talking about how basically it has to do a lot with the cavity size. Like, so if you can get the Foley in and the cavity size is too big for the balloon, then it's not going to be effective.
Right.
One other thing,
The classic position for bleeding is under the clavicle, right?
yeah,
So we'll talk about this in trauma, although most people don't do it. You have subclavian vessel injury. You float a Foley underneath there because you can't see where it's bleeding from. You inflate the Foley, and then you compress the vessel against the clavicle with the Foley.
yeah, and I've seen it, a lot of them neck too as well.
Yeah. Those spots you can't see the bleeding. But nowadays we have all these hemostatic dressings and stuff.
Yeah.
And the new one just came out that wound clot, right? And wound clot, you can pack the face or the chest. The first hemostatic dressing available in the market, you can actually pack it and you leave it in forever, right? So we take a patient to the OR, you can pack in the OR and just leave it in.
They also have this trauma gel that I guess is coming. That hasn't been approved by the FDA yet, but they have a basically a veterinary version. It's like a gel that you put in. It's like plant-based, and it's kind of looked like the studies looked like it was pretty good for arterial injuries as well.
So wait, so this wound packing, the way that you can put in the chest, they leave it in and it just absorbs,
Just
or
absorbs.
interesting. So it heals by secondary intention then.
Yep. Yeah. And it stops bleeding really quickly. And the thing is about wound clot is you don't need to put a lot of pressure on it. Like the other hemostatic dressings,
You have to
you're
hold-
supposed to
yeah.
put pressure on.
Yeah.
This, you just barely any pressure whatsoever.
Cool.
So they have like videos. The company does. I saw it. I was where was I? I forget. I was somewhere. They brought me out there a couple of months ago, and it's really cool. So the other hemostatic dressings you can't pack into the face or the chest. It's not recommended.
Yeah.
This one is just a different chemical, so you can do it, and you leave it in forever. And so it competes against wound clot, but it does other things. Without all the pressure. So they had like example of like some sort of animal who was shot in the groin, and then they just put it on just gently and stopped the bleeding pretty quickly.
That's cool.
So they compete against like combat gauze and all
Right.
those type of things.
That would be super useful, like on our tactical jobs, something like that
Right.
with the dogs.
Yeah.
'Cause
Well, we
there's-
have one cloud on the vehicles.
Yeah, we have that.
I think it's a
That's-
yellow or green package.
Is that I thought that is that the same one that we don't have to? I thought that was the one we still have to put a lot of pressure on that one. Am I
So
thinking of it wrong?
the wound clot, you don't have to put a lot of pressure.
Not the
It's
yellow. Okay,
gentle.
that's the yellow one.
Right.
Okay,
Got
okay.
The other stuff like the
Some
combat
nuances.
gauze, the other
Yeah.
hemostatic, put a lot of pressure.
Okay.
And
Cool.
so cutting edge stuff.
Yeah.
All right. Any other comments?
It's kind of a neat looking device. If you Google
Yeah.
a picture of it,
Yeah,
it
yeah.
looks like a big syringe with like a little bunch of tiny little sponges in it, and
Yeah.
it's like it would be easy, portable
To
to
do it.
keep on our
All
person.
All right. So the minute we
Yeah, I was just gonna say it looks like pills.
the minute we can get it, we'll put it on the vehicles.
Okay,
That's cool.
Yeah, there's the two
I have a spot
sizes
for it
of
on my list.
The 30
Yeah.
and the 12.
I'm ready.
All right. What's the next article?
Let's see. I think the next one is our crush injury paper that was published in GEMS.
All right. Good.
So this was cool. So this was an article that I was able to help with, get involved with the editing process and work on this with some of our fellows from last year. The primary author is Dr. Drew Parrish, who graduated the program last year, who I think is out helping us out today. Job. So we appreciate you. Thanks, Drew. So basically, this article was published in the Journal of Emergency Medical Services, and it discusses managing the chemical release that occurs during a crush injury. And so it focuses on it starts out with a case study and then goes on to talk about what are the primary things that you have to be concerned about during a crush injury. And a lot of it is, as you would expect, electrolyte management and understanding that the problem happens when a patient is entrapped or they have a limb that's, impinged underneath something. And when you remove that something, then you get the release of all the chemicals. And like in my mind, I thought about like the obvious ones, like obviously potassium and myoglobin were some of the big ones that, arrhythmias and kidney damage. But some of the other ones that I like before I read this article and got involved in like editing it, wasn't really aware of were things like histamine release, which when you think about somebody having an allergy response and why we give epi and things like that, like you might not expect it in a patient who's got a crush injury that they could have dyspnea and difficulty breathing, and you might end up having to give something to combat that histamine release. Just something to think about. And then a discussion about remembering to treat pain early and before you're even like, especially if you're in a situation where your patient is entrapped and they're not able to get out, like start an IO on whatever limb that you can get access to and give a medication for pain that's not going to affect the blood pressure, because hypotension, hypoperfusion is a big issue in this type of injury. So you don't want to drop their pressure. So the example the article gives is fentanyl. It's a great drug. It's quick on, quick off, quicker than morphine, but it's only going to help your patient in terms of their ability to handle the injury. So,
right. I remember an article we reviewed a couple of years ago now from Israel, where they had people entrapped who had crush injuries, and the only exposure they had were like the feet and the ankles, and people who got no fluid almost all went into renal failure and had bad outcomes. And the people who they just like put an IV in the foot and just gave fluids that way, none of them went into renal failure. None of them had rhabdo.
Yeah.
They just gave fluids your entire entrapment period.
So
get fluids in somewhere.
100%. So my favorite, I think the best takeaway point from this whole article is the quote that says like, delay in fluid resuscitation can increase incidence of renal failure up to 50%. The incidence of renal failure is almost 100% if fluid resuscitation is held beyond 12 hours. So you got to find a way to hydrate these patients. And the other thing is obviously avoiding LR would be good because of the potassium content when you're worried about hyperkalemia in these patients after the release of whatever's causing the crush syndrome. So,
but in general, we do know that LR doesn't cause hyperkalemia.
Right.
But we will add to that saying that these people have a higher risk for hyperkalemia. This is why I know the paramedic textbook it talks about. People don't understand. It's not paramedic textbook talks about giving bicarb for crush injury, and people don't understand why. And the answer is it's all silly and made up because bicarb doesn't work very well for hyperkalemia to start with. But that's just why it talks about bicarbs for rhabdo, because they're trying to prevent hyperkalemia. But there was 2 studies that both said it doesn't work very well.
And it hasn't been shown to assist with any release of the lactic acid that you're going to get from muscle breakdown either. And same thing with mannitol. It doesn't help with the acidosis really at all. So they need fluids and pain management. And then I think one of the bigger takeaway points too from the article is if you don't see an end in sight to this patient's, limb being entrapped or whatever, you have to consider amputation. If it's the patient's life versus releasing all those toxins in the end, I mean, the amputation has to be somewhere in the back of your mind.
Just to be clear, we're not saying give fluids for somebody who's entrapped for a couple of minutes, right? I mean, we're not big fluid people during trauma. I mean, this was all Ken Maddox's literature to say if a systolic's 90, be happy, and you could just go to the hospital, right? Because nobody leaves normal saline.
Right.
It's much different if somebody's entrapped with a crush injury for a prolonged period of time. If you get there and they're going to go, we'll be out of here in 15 minutes, we're not filling the patient with fluids at all.
Right. And so those patients I think would be, you could start an IO if you could get IV access and give them some sort of pain management in the meantime, then it's going to be a quick extrication, then get in and get out. But yeah, definitely this is, and the article comments on this as well, like this is a very unique type of trauma because in most traumas we don't give fluids. If we're going to resuscitate, we want to get blood products and that kind of stuff. But this is different if it's prolonged. So
and with the whole country, well, not the whole country, but more people going to it's whole blood for trauma. Right? That's been talked about for a couple of years. I'm actually trying to get the blood in our physician for us because we use some packed red blood cells right now. This is what John Holcomb put on 2 of his vehicles in Houston. Just whole blood. Again, nobody believes packed red blood cells. So this is very in vogue for trauma to get whole blood, even though it's a little more difficult and a little more expensive.
And then I think the only other thing that I took away, well, not the only other thing, but the one thing that I would remind people of is when you have somebody that comes into the ER after something like this, just remember that you want to stay away from nephrotoxic drugs. So like if you're trying to manage their pain and you're like, I don't want to give them narcotics because it's going to drop their blood pressure, ketorolac is obviously not a good choice because you're worried
Right.
about renal damage to begin with. So it's just important to keep in mind, because I feel like that in an otherwise young and healthy patient who has like musculoskeletal type of pain, we're like, yeah, ketorolac's a great drug, or like if it's a renal colic or whatever. But like this is obviously a time when you should not use that drug.
Right, or if you worry about somebody with active bleeding.
Right.
I would worse to give a non-steroidal.
I had a super interesting case actually of a patient who overdosed on something, and he actually laid on top of a pipe for about 20 hours. He was passed out. No one heard from him for like a day. And he presented to the hospital with leg pain. They did an x-ray. They said, well, it's not broken, and sent him home. And it turns out crush syndrome works in both ways. So technically, his leg was freed, but he was getting crushed from right underneath his leg. They crushed his posterior compartment of his thigh, and he presented to me in renal and liver failure at the same
Wow.
time.
Did he
Rhabdo.
still have did he have compartment syndrome?
By then, it actually had somehow it resolved. Like it wasn't still like it had, I guess, become a compartment syndrome and then resolved with him walking around for a day after.
Well, that's interesting, because usually that's resolved
Anything.
spontaneously. Usually they have to do fasciotomy.
It was for so long, I guess, that he got up and walked around and had no
Maybe it
idea
was
this was
just
going
like-
on and it decompartmented.
Maybe the muscle just became necrotic and shrunk. I don't know. But you think that the
Crazy,
edema
that's-
would make it worse.
You would think so, but the point is, like, he presented just like that, and I wonder if like he would have presented to me differently if the first hospital had recognized it and had hydrated him appropriately,
Yeah.
Right, right.
and it probably could have been, but
Yeah, I guess I don't know that I would have made that mental, like just thinking about if a patient came in and said my leg hurt and couldn't offer that appropriate history and say like, this is 100% what happened. I fell asleep on, and I was in this one position for X number of hours. I don't know that I would have thought about that.
Right. We have that one, young female at camp, what I'm talking about, who has had a spontaneous compartment syndrome.
Oh,
You know what I'm talking about?
yeah.
So, I think she was like 15 at the time, went to like a couple of emergency departments just complaining of severe tip pain, and had an atraumatic compartment syndrome, and wound up, with a 4-compartment fasciotomy, and just worsening pain. So somebody imaged her, said it makes no sense. Somebody had to strike and put a pressure in, and her muscles all became necrotic.
Yeah.
But a young 15-year-old girl with spontaneous atraumatic compartment syndrome.
It's a little strange.
It's like that's why I remember the case, because it's
Oh,
like a
man.
case report,
Yeah.
right? But I guess it just proves you that if somebody comes, if you're the 5th ER visit, do more.
Do
Right,
something
exactly.
more.
I'm glad we did.
Get other people on board to share, just to share the problem.
Right.
Yeah.
All right, other article.
Yes. So the last one is an accepted manuscript to go in the Resuscitation Journal. It's trends in overdose-related out-of-hospital cardiac arrest in Arizona. So the aim of the study was to identify trends in overdose-related out-of-hospital cardiac arrest compared to cardiac causes or cardiac etiology of out-of-hospital cardiac arrests. So it was a statewide observational study. They used the SHARE registry to identify all patients that had out-of-hospital cardiac arrests, and then ultimately included those who are deemed to be overdose-related or cardiac in etiology. So of those, they found that the total was 18,562, and 95% of these cases were still cardiac in etiology, and about 5% were overdose-related. They found that the mean age for the patients with overdose related, they were much younger, likely to have less comorbidities, were less likely to have an initial shockable rhythm, and had a higher overall survival to discharge when compared to the cardiac patients. They did an adjusted risk assessment and found that patients with overdose-related cardiac, out-of-hospital cardiac arrest had an odds ratio of 2.1 compared to those that were cardiac in etiology. So from 2010 to 2015, they saw that there was a clinically significant increase in the number of overdose-related out-of-hospital cardiac arrests, going from about 4.2. Sorry. Yeah, I know.
Yeah.
It was overall 5.2% increase, but they found that from 2010, 4.7% to 6.6%, and found that the largest increase was in 2013 to 2014. So overall, there is an increase in overdose-related out-of-hospital cardiac arrest. However, these patients do have better survival.
I thought it was interesting that they commented too about how that the patients with the overdose related arrests are less likely to have a shock of rhythm. And so that like points to the fact that we need to keep pushing like education to the public about good bystander CPR, because that's the biggest thing that's going to save these people is somebody recognizing that they're not breathing and they don't have a pulse and just getting on the chest and starting CPR, even if you don't know exactly what the rate is or whatever, but you're doing deep compressions and you're not giving any breaths for them because some people feel uncomfortable with that. If you can at least give somebody compressions right away, I mean, that could make the difference legitimately between life and death.
I think they did say that overdose related were less likely to have bystander. There was something, but it wasn't clinically significant.
Right. They commented on how they thought that there was going to be less bystander, or there was less bystander CPR initiated, and I wonder if that's because of the environment that the arrest happens in. Like if this individual is using like heroin or any other narcotic that's going to cause them to overdose and they're in the setting where there are other people using the drug, the other people are probably just thinking that they're high and they're not recognizing that they're not breathing anymore.
Right. It's all this stuff we do has got so little to do with us. It's, when somebody drops, who's there to help somebody.
Right.
And it's never us, right? It's all the bystanders. What are they going to do? It's all this Stop the Bleed campaign, or who's doing CPR, or where the oxygen tank is, the AED is. By the time we're getting there, it's just, even though it's a couple of minutes, it's too late. Have you guys ever been somewhere like in a public setting where somebody dropped, where you just weren't working? Like not in a squad, or just, or on, almost everybody, it's kind of funny, almost everybody except for me has had a medical emergency on a plane when they were just kind of like.
I had emergency on a plane, but they were still conscious.
I had one on my most recent flight. I had one for a gentleman who was younger, healthy guy who was.
And you weren't working.
Having a little. I was on a plane, and he was a little bit anxious. It seemed like he's like, "Oh, I can't sit back there. There's too many people there." So they brought him up front, and he was hyperventilating. And the crew that happened to be on the plane, their response to this was actually, interestingly enough, to give him oxygen. And I identified who I was, and I saw this happening in front of me, and I recommended to them not to do that. And they said, "This is our protocol. This is what we're doing." And I said, "Okay, then." And it was a long flight, so I took a nap, and I woke up, and he was then laid across rows with his feet up, because at that point he felt like he was going to pass out. But because he was hyperventilating while on oxygen, so he obviously ended up in that state. But.
Well, and then I had the flight with where I was actually working, and it was like transporting a patient to Kuwait, and my patient was fine, and there was another passenger on the plane who did not look good, and I was like worried that this person was not going to make it to Kuwait. It was terrifying, because you're like up in the air and you're like, I have such limited equipment, and they're.
At least you had some stuff, right?
Oh yeah, I did have some, and I had a very excellent skilled paramedic with me, which also it made me feel more comfortable because I had a second set of hands. She did fine, luckily, but yeah, I've never had somebody drop in front of me. I have done the Heimlich on one person in a public setting, but otherwise I've never. Yeah.
My husband, actually, I forgot about that. So my husband, I swear to God, so I forgot about that. No, but he got knee surgery. Hi Dave, if you're watching. So he got knee surgery, and he was on pain medications and was not hydrating properly. And he stood up and went to walk to the bathroom, and got about like halfway there and said, "You gotta come here. I think I'm gonna pass out." And lo and behold, he actually did. I was able to catch him. And you know what? When you see syncope in front of you for the first time, it's terrifying. Totally understand what everyone's talking about.
Shakes, and now I know what people are talking
exactly.
about.
He had a little bit of the shake. He stopped breathing. He turned blue for a second and came to. And as I am. At the time I was a resident, so physician just checked his pulse. He's still breathing, laid him down, and But even that checking the pulse is a huge step in these overdose patients. We don't think about it right away.
Right.
And, you know, especially if you're responding to someone in a bad area on the road, like, you don't, it's terrible, but sometimes the first thing we think about is like, oh, they just overdosed, let's give them Narcan and see what happens. But you still have to, I think, remember that these people still are sick. And,
Right.
you know, if one thing doesn't work, you got to start compressions earlier, because as we know, that's the only thing that works.
Right.
Early CPR, you get CPR. So.
Right. When you're in the middle of it, you react differently than. I mean, I remember this was years ago in the PZR at St. Barnabas. 15-year-old girl brought in by her father, just like it's seen out of ER, running into the ER from the car, parked illegally in the ER entrance, throws his daughter at one of the nurses who's seizing. Actually, you know, I'm wrong. She was like 5 years old, not 15 years old, right? Simple febrile seizure, but what happened is the whole staff was there, and it's such a bigger deal. They put an IV in right away. They drew all this blood work right away. They did all this stuff right away. And in 30 seconds, she was like totally fine. And I thought, why do all these people who know better like react?
Right.
And
Right.
the answer is because they were like in the middle of it.
It's the adrenaline.
Right. It's the
too.
adrenaline at that moment. Everybody just started doing stuff automatically. Right.
Right.
And it's, you know, I mean, Dan Friedman he was on a flight not associated with work. And he had a kid who went to cardiac arrest with a lot of like congenital anomalies, and he did CPR on the kid on this public plane. And a lot of people, Mike Westrall had a kid going to Kuwait who went to cardiac arrest. A bunch of people did, but I never have. I've never had for all the flying I do. I've never had one person.
Yeah,
That's a good
right
thing.
now.
That's
Right.
okay.
I nap a lot, so maybe.
It could be happening and you don't even know
Right.
it.
But I did have the one when we went to California, the seizures, the syncope.
Right, you had that. Matt
there's a bunch of
Harris,
others,
Matt
yeah.
Harris, and Matt Harris had somebody who it was a simple febrile seizure on a plane, and I remember he reported a case here, and I said, when you went over to the mother, did you say like I'm one of the only chem EMS docs in the entire world, and you just happened to stumble across me? What's her name? Marinella? No, Marinella.
Marinella.
She had a kid she had another febrile seizure on a plane, and they were calling an ambulance to take the kid to an ER, and she said, well, I'm actually a pediatric emergency medicine, and your child doesn't need to go to
It's
the
fine.
ER.
Yeah.
Right? And I'm thinking, that's great. I mean, it's somewhat a risk of reliability, but she also actually had to sit next to this family for like a while, so she got to observe the patient.
Yeah.
Right.
That's interesting.
I was going to say, in regards to the article, I think that the other thing to take away from it, which I think a lot of us do anyways, but if you're not, at least consider if you have a young patient and an unidentified like reason for cardiac arrest, Narcan should be part of the things that you like when you
Yeah,
check
just give
a
them
blood
Naloxone.
sugar, give them some Narcan.
That was our study, right?
Right.
That was our study. We published that.
Right.
If it crosses your mind, give naloxone on cardiac arrest. What's the downside?
It's not going to hurt them if it has nothing to do with an opiate overdose. It can
And
only
people
help.
say, how
so.
should I dose it? I would say, I'll make up some number for you if it makes you feel better.
Right.
Right.
You know, give 2,
give it-
4, 8. I mean, we
Right.
the answers we have no idea.
Right.
And the adept things now are like 4 milligrams. So just give the whole freaking
Right.
thing.
I'd rather
we
have
don't
them
know.
wake up and throw up on me than die.
Yeah.
So
Right. Right. Just give it a bunch. What's the downside? We don't do that one cardiac arrest, and we don't do calcium on cardiac arrest for the risk of hyperkalemia. Right?
Yeah.
All right. Anything else? Do we want to do one more?
I don't know if I think we only had 3 this
We
week.
only 3.
Yeah.
Okay. All right. That's good. We can work on some operation stuff. So this week, let me see. Friday is the big Jersey Shore Trauma Symposium.
Yeah.
That looks really good. Last I heard, so I'm giving a lecture, and last I heard they had 150 people coming. And they got a lot of big name people from all over the place in adult and pediatric trauma. So it should be really good. They have a bunch of like medically pretty intense lectures, so it should be good. And that is this Friday.
Friday.
And what else? And I think that's it. Any other announcements? No. Okay. All right, everybody. So we're going to end quickly, just to get back to some operations. Thanks for tuning in, and we will see you next time.